Hey everyone, Tyler Lavoie here, financial planner. So quick question for you. How much of your healthcare costs in retirement do you think Medicare actually covers? Most people guess most of it, but the real number would actually surprise you. And that gap is where a lot of retirement plans quietly spring a leak. Today, we're covering Medicare, what it actually pays for, where the surprises may hide for you, and how it connects to your retirement income plan. Because I see this constantly. People spend weeks planning for a 2-week vacation, and then they retire with almost no plan for the biggest reoccurring expense they'll ever face for the next 20 plus years, healthcare. And the numbers really back this up. Medicare only covers about 60% of total healthcare costs in retirement, according to the Employee Benefit Research Institute. And even Fidelity's healthcare cost estimate puts the after-tax savings a 65-year-old couple may need for healthcare at around $330,000. And that doesn't even include long-term care. And I'm not sharing this to scare you, but what I'm trying to explain is the people who plan for it tend to retire with a lot less anxiety than the people who don't. So here's the game plan for this video. So we're going to cover the 4 parts of Medicare and what each covers. So this is original Medicare versus Medicare Advantage, Medigap, and then talking about IRMAA, which is the surcharges that catches more people off guard than almost anything else in the system, looking at Enrollment Windows and how it all connects to your broader retirement income plan. So let's answer the first question. Well, what is Medicare? So Medicare is government-sponsored health insurance. It was enacted in 1965 for people 65 or older, people with certain disabilities, or people diagnosed with end-stage renal disease. And here's the part that surprises people. It was never designed to cover everything because it only covers 60% of total healthcare costs, and it doesn't cover most dental, vision, or hearing care or long-term care. So the real question a lot of people ask, well, one, does Medicare cover me? But what's the actual plan for the other 40% gap? And so Medicare has 4 parts. So there's Part A, which is hospital insurance. This includes inpatient stays, skilled nursing facility care, hospice, and some healthcare. Most people don't pay a monthly premium for it since it was already funded through payroll taxes during our working years, but no premium doesn't mean no cost. And so if we're looking at the deductible, if we're looking at 2025, the deductible was $1,632. Days 1 through 60 of a hospital stay really carry no coinsurance, but days 61 through 90 run $408 a day. And days 91 to 150, the lifetime reserve days jump to about $816 a day. And beyond that, the patient covers all costs. So for an extended stay, those per day numbers really do add up fast, and exactly the kind of gap Medigap or Medicare Advantage can still fill. And so what is Part B? Part B is really looking at medical insurance. This is looking at doctor visits, outpatient care, preventative services, durable medical equipment, and some health care. This is where the income starts to matter because the monthly premium ranges from $185 up to $628.90, depending on your income. And we'll get into exactly how that works in a minute, but there's a $257 annual deductible, then 20% coinsurance on most services after that. And here is the detail that trips people up the most. There is no out-of-pocket maximum on Part B, none. That's the single biggest reason people layer on a Medigap policy or choose Medicare Advantage to put a cap on that overall exposure. And so let's talk about IRMAA. This is really what I want people to hear most because it's one that generates the most confused phone calls every January. And IRMAA stands for Income Related Monthly Adjusted Amount. It's a surcharge added on top of your regular Part B and Part D premiums. And here's the twist. It's not based on this year's income. It's based on your tax return from 2 years ago. So someone can retire, have a lower income this year, and still get hit with a higher premium because 2 years earlier, they were still working, took a large withdrawal, or had a Roth conversion or big capital gain that happened. And so the system is looking backward, not at what's happening in your life right now. So if you take a look at for this graph here, we're looking at 2025 brackets. A single filer under $106,000 in Magi pays at a standard $185 a month for Part B, and you cross into the next bracket, $106,000, $133,000, and those premiums jump to $259, and they keep climbing above $500,000. Part B alone is $628.90 a month per person, plus a Part D surcharge on top of that. And this is exactly why a single large income event, a Roth conversion, a big RMD, selling an investment property can quietly cost someone thousands 2 years later in higher Medicare premiums. And there's an appeal process using the form SSA-44, but it's only available for specific life-changing events like the death of a spouse or divorce, not general income fluctuation. So let's talk about Part D, because this covers outpatient prescription drugs through private plans approved by Medicare. The average monthly premium runs around $40 with a maximum annual deductible of $590. And here's genuinely good news. Started in 2025, there's an annual out-of-pocket cap on the covered drug costs. So this isn't a one-size-fits-all, but the direction is a positive one for retirees. Let's look at Medicare Advantage versus original Medicare, because one of the biggest decisions is really looking at these two, and it's also called Part C. So Medicare Parts A and B together gives freedom to see any provider in the country that accepts Medicare. No referrals needed and pairs well with a Medigap policy for predictable costs. The trade-offs though, no out-of-pocket maximum without that supplement, no built-in drug coverage, and no dental, vision, or hearing benefits. Medicare Advantage plans are run by private insurers and often bundle in drug coverage plus extras like dental and vision with a real out-of-pocket maximum. The trade-off is a private HMO or PPO network, so provider choice can be a little bit more limited and plan options vary by county, but neither path is universally better. It really comes down to how someone really values the provider flexibility versus overall cost predictability. And it's worth a conversation with a professional who really knows the full picture before you make a decision on these. So if someone chooses original Medicare, a Medigap policy fills in the gaps, coinsurance, co-payments, and deductibles that original Medicare leaves exposed. So there are 10 standardized plan types, A through N, with the same coverage no matter which company sells them. Plan G tends to be the more comprehensive option for new enrollees since Plan F was closed in 2020. And so timing really matters here, and there's a 6-month guaranteed acceptance window after starting Plan B. And if you miss it, and enrolling later may involve medical underwriting. So a carrier could actually decline coverage or charge more based on health history. So let's talk about timing in these enrollment windows, because this is where we can try to avoid penalties. The initial enrollment period is 7 months. So 3 months before the 65th birthday, the birthday month, and then 3 months after. So still working with employer coverage, there's a special enrollment period. So this is 8 months after that coverage ends. But if you miss both, and general enrollment runs January 1st through March 31st each year, October 15th through December 7th is open enrollment for switching Medicare Advantage or Part D plans. So the costly mistake I see most often is people who keeps working past 65, but assumes they're automatically covered and never confirms whether their employer plan actually qualifies for that special enrollment period. It is worth confirming with HR well before the overall transition. And so how does Medicare affect your overall retirement income plans? Because if we're zooming this out, because Medicare isn't a standalone decision, it's connected to everything else in a retirement income plan. That IRMAA surcharge can add up to $487 a month per person at the highest bracket, $5,800 a year, and healthcare costs coverage tend to rise around 5% a year, faster than general inflation. And here's the connection that catches people off guard, because IRMAA looks at income from 2 years ago. Decisions like when to take required RMDs, start Social Security, or convert to a Roth can all shift that overall in Medicare uses for that calculation. So a choice that looks smart from a tax perspective this year might quietly raise Medicare premiums 2 years from now, which is exactly why healthcare income planning needs to happen in the same conversation. You can't do with one without the other. So what can actually be done with this? And a handful of strategies are worth understanding because each has trade-offs and none of them are universal answers here. Roth conversions move money into an account where future qualified withdrawals are excluded from your MAGI, your modified adjusted gross income, the figure that drives IRMAA. So the trade-off here is the conversion itself is taxable income in the year it happens, which can temporarily raise your MAGI. Maximizing pre-tax 401k or 403b contributions while working reduces your current MAGI, but larger pre-tax balances mean larger required minimum distributions for you later, which then could raise your MAGI down the road. So municipal bonds are great because they generate interest generally that's excluded from MAGI, though they typically yield less than comparable taxable bonds. And reviewing RMD timing can help manage MAGI in key years, though RMD rules are fixed by law. For specific life-changing events, death of a spouse or divorce, you can file that overall appeal form. So it's the form SSA 44, though it doesn't apply to general income fluctuations. And the last one here, try to work or talk with a financial advisor who can help you coordinate tax, income, and healthcare decisions across the full plan, rather than just looking at Medicare in isolation. Because advisory services do involve fees and the results are never guaranteed, but coordination is where a lot of the value shows up. And a lot of the times they can connect you with the right person too to help you accomplish with what you're trying to accomplish. They're very good at being conduits to solutions. And so, Medicare has a lot of moving parts, the 4 parts plus IRMAA, plus enrollment timing, plus how it connects to withdrawals and our overall required minimum distributions. And none of that has to be figured out alone. And it definitely doesn't need to be figured out in the first time the week of a 65th birthday. So if you want to walk through your overall specific situation, I invite you to book a complimentary 15-minute chat. You can use the QR code here on the screen, and we can see what we can do to improve your situation. My name's Tyler Lavoie. Thanks for watching, and I'll see you in the next video.